Hey, good afternoon. Jose Almeida here, IVC community. We did a little case this week I wanted to share with you. It's fairly common when these older folks come in, they got the gators or area of the medial malleolus full of these dilated vena ectasias, and then they get in the shower and then a little thinning of the skin and they bleed in the shower, and it's impressive. And if they're not prepared for it, they call rescue and a big ordeal. I bled like an artery. Anyways, I think we've all seen this, and we've got a case, and I'll just show you how I approached it. So you guys can see this. And we'll get in here. So this is an older gentleman, like I said, in his 80s. And this is the area, and you can see these little dilated veins, blebs, little pre-ulcerative, and this is the area that's bled several times. So here he is on the table, the leg, the ultrasound up here. Here's the great saphenous vein. And we're just scrolling down. I just want to show you a couple things. One, this tortuosity from a perforator from the mid-thigh. This is leading the femoral vein. So we're going to have trouble getting through the vein at that level. That's one of the reasons we use the Venclose catheter, radiofrequency ablation. It has some torque to it, and it's good for navigating kinks. You can see the vein is dilated all the way into the calf. So then the argument becomes, how low should we go and the risk of saphenous nerve injury? So our group in Miami published this paper a couple of years ago on treating the below-knee saphenous vein. And the bottom line, you get better control of reflux the lower you go, but you have a higher risk of saphenous nerve injury. Now, in this gentleman, he's more worried about his bleeding than the saphenous nerve. So we went low to control the reflux, and I don't think a paresthesia, if it were to occur, would be a big deal for him. So here we are accessing low, inserting the Venclose catheter. And here you see me torquing the catheter, trying to get through the first kink. And we got through there, no problem. And I'll speed this along for you. I think they were moved along here. And at the top, there's a couple veins up here, and the catheter was going in the wrong one. So I'm pulling back and torquing to get it in the correct great saphenous vein, this one. All right, then we park it at the saphenofemoral junction. So that's just the advantage of using the Venclose torqueable catheter. The other piece is the perforator in the mid-thigh. So we went ahead and injected foam directly into the perforator. Will it close it? Might help, might not. It'll probably reopen and be a source of recurrence in the future. But we're there. Go ahead and just foam that perforator in several spots. You see, I'm going to go for the upper one now. Get a little foam in there, massage it in, and people worry about femoral vein, deep vein thrombosis after this, and it won't happen. There'll be foam going to the femoral vein, but it shouldn't cause a DVT. We like to move the leg around, do the procedures quickly, and have them get up and ambulate immediately so the circulation is moving. All right, so we foamed the perforator here. Then next at the bottom of the ankle, we sort of treat these like we would a venous ulcer. There's this venous plexus beneath the skin, and we want to fill it with foam. So we're going to do that same principle down here in the foot. Yes, it's a little sensitive down there. We got to give a little conscious sedation. Now, my camera person didn't quite get the ultrasound and this together, so you're not seeing the whole thing, but you see this filling up with foam and me injecting down in the low foot. And I think we're going to do another couple of injections. And it looks like here, we're going to show you the foam. Here it is in the below knee saphenous. You see all the edema and the foam in the superficial veins also up here. All right, so that'll go into these vena ectasia that we're bleeding. We control the reflux with thermal ablation with radiofrequency, and he should do well after this. All right, what else we got here? So now we're going to do the actual ablation. There's a catheter to saphenofemoral junction, and I think I've shown before the tumescent anesthesia is already in. Here's a tumescent around the vein. I like to use the handle of the catheter right here. So I always use the long catheter so I can reach now with the handle of the catheter. Let me show it to you again. I like to get that handle and use that to compress the heating element. The heating element is 10 centimeters long and the ultrasound probe's 4 centimeters long. So I'm up here compressing. There you see the heating element being compressed from above. Let me see if we show it again here. So here I'm pushing with the handle and the ultrasound probe so I get a good at least 10 centimeters directly on the heating element. And again, this works by conduction. So you have to, or I like to apply pressure. I think you get a better result. So that's it for this week's case, how to control bleeding from the ankle on older folks with Saphenous reflux. Thank you, and hope to see you at IVC.